Hello, good afternoon, everybody. My name is Lisa Beth Doyle. I'm the manager of health and wellness at Always Health Partners, and thank you for joining today's webinar. Um, February is American Heart Month and a time for us all to focus on keeping our hearts healthy. And with that in mind, we thought a very helpful topic would be cholesterol. We all have cholesterol in our systems. In fact, a tiny amount of cholesterol is necessary for certain body functions. However, too much cholesterol is a significant risk factor for heart disease. And to give us more information about cholesterol, we thought we should bring in the expert. So I'd like to introduce today's speaker. It's Dr. Christopher Cannon. He is the education director at I'm going to mess you up, I'm sorry, Cardiovascular Innovation Preventive Cardiology section at Brigham and Women's Hospital and a professor of medicine at Harvard Medical School. So let me hand this over to you, Dr. Cannon.
Well, thank you very much, and thank you all for joining. It is a good topic to talk about, and lots of advances, and one in particular that Always Health Partners offers to all subscribers that I'll talk about, a wonderful program in trying to help manage cholesterol. I'll begin with, we in all lectures will list out disclosures of all the different companies that we've done research studies with over the years or serve on scientific advisory boards. And so there's a list of all the various companies that have a lot to do with coronary disease, cholesterol, et cetera. So we'll begin with what is heart disease, and I'm focusing on coronary heart disease, which talks about the heart and in particular the heart arteries that are shown here. And so the process that we think about of heart attacks begins really with plaque building up in the heart arteries. So cholesterol, scar tissue, inflammatory cells will attach on the inside and then grow within this artery, and that can reduce how much blood goes through the artery, reduce how much oxygen gets to the heart, and that process usually takes decades, usually if there are risk factors like high cholesterol or high blood pressure, et cetera. And as I think everyone knows, the cardiovascular disease is the #1 cause of death of men and women worldwide. So digging down one level lower, here's a time warp of an artery over, say, a 30 or 40-year period. And so on the left is a normal looking artery with smooth blood vessels, the lining on the inside. And then you see that there's cholesterol floating through the blood that often increases over time. And then in the middle section, you can see it starts to get into the edge of the vessel wall. And so that's a plaque, a cholesterol plaque that again has inflammatory cells and calcium and other materials building up in there. So the fifth panel shows a break in that plaque. So a rupture of the plaque that then the dark red stuff is actually a blood clot that forms on the surface there. If there's a tear inside the artery, the body says, what's this? We've got to plug that up. And so a blood clot can form. And you can see if that gets big, it'll block the artery entirely. So that's what a heart attack is that the plaque ruptures, a blood clot fills the artery and blocks blood flow to either the heart, or if this is happening in the blood vessels to the brain, that would be a stroke. It can happen in the leg vessels as well. So then, of course, we have lots of treatment. We get rid of the blood clot with anti-clotting medications and try and stabilize things. But this is a recurrent process that can happen over time, and hence the desire for prevention and trying to stabilize these plaques as much as we can. And so for terminology that you may hear, the main terminology we say in prevention is it primary prevention or secondary. And so simply primary prevention is preventing the first event. And so it would be in people without any known heart disease. And our goal is to modify risk factors and prevent the development of plaque, et cetera. Secondary prevention is all the same tasks, but in people who did actually have a heart attack or they needed a stent. So they have manifest heart disease. And so now we're trying to prevent a second event and really quiet things down. And those patients, obviously, who've had one event are at highest risk of having another. Now, in between the two, many people will have a CAT scan or sometimes a dedicated test called a cardiac calcium score that can look to see, are there signs of plaque building up in the heart arteries? One can also do an ultrasound of the neck and look at the arteries going to the brain. And as illustrated here, a calcium in a plaque correlates with how much cholesterol is there. And the more buildup in the arteries, the higher risk of developing a heart attack or stroke or even death. And so this is a factor that it's in between patients who've had a heart attack versus just with risk factors that we're doing more and more to see, could we get an early assessment of whether plaque's building up? So what do we do? Well, one little easy way to remember is to use sort of the ABC and then DE as illustrated here. So there are lots of things, fortunately, to help on prevention. So we talked about how the blood clot can form. So using antiplatelet therapy, and aspirin is the leading one, Plavix, and there are lots of other different agents can be used. Controlling blood pressure is obviously important, and that begins with lifestyle changes and exercise and things, but then medications. C includes cholesterol and also cigarette smoking cessation. Diabetes is a key major risk factor for cardiovascular disease, and so that can be managed as part of all this. And then diet and weight management, and then exercise are all things that we kind of know, but we have to go over each time when I'm in the office. Well, review what kind of things do you like to eat? What do you do for exercise? And get a sense of, is it up to what the guidelines would recommend for that? So turning to cholesterol, it has been an amazing time in the treatment of cholesterol. And it's just about 50 years, I guess it's a year and a half past the 50 years now, since the first study was published to show that lowering cholesterol will prevent cardiovascular disease events. And so this is a busy slide, but it lists out all the major categories of ways that we've studied and shown the benefit of lowering cholesterol. So the first one was using a healthy diet. The second one was using something that blocks absorption of cholesterol. The fourth one lists out statins that have been the revolution, and HD is high dose statins are even better than using regular dose statins. Other classes of drugs have modest effects, fibrates and niacin, but then ezetimibe and PCSK9 inhibitors are classes, and I'll show you some of the actual research that further lowering the LDL on top of whatever the statins can do leads to reductions in heart attack, stroke, death, et cetera. So I wanted to share with you, the real data. So this would be an example study of how we test whether something works. And so this was a study of about 20,000 patients who had high blood pressure and risk factors, and a moderate cholesterol, not terribly high, hadn't had any heart attack before. And this was done 20 years ago, randomized them to so half the people got atorvastatin, one of the statins, and others got placebo. And so then they track over time how many people had a heart attack or died of heart disease. You can see the curve in blue is getting a statin. Almost immediately, you had fewer numbers of people having a heart attack or dying. So much so that the study had to stop early because it was so clear there was a benefit of taking a statin that they didn't think it was fair to give people placebo. And so this is an example of a low dose of a statin led to a reduction by a third in your risk of a heart attack or stroke over just a 3 to 3.5 year period. So there have been tens of large studies like this. This is sort of one slide that we look at that put 26 of these large trials together. And for every 40 points that the LDL or the bad cholesterol comes down, you have a lower risk of heart attack, which is the first line, death, CABG is bypass surgery, PTCA is stenting and angioplasty or stroke or any of those. So very, very consistent. Every single study will show the benefit of lowering cholesterol. And so this is often, if we have to show one slide, I'm sharing that with you so that you've seen the evidence from, this is 176,000 patients are included. Now, another way that we look at this is an interesting plot where across the bottom is the level of the cholesterol in the different studies. And so the P is the placebo, and then the S is the statin. And when people plotted out all the different studies, a very interesting thing was seen, that the lower the LDL, the lower the risk of cardiac events. That's plotted on the left. And you can see that the lower that thing, the better people do. And so the mantra that we've adopted and has been borne out in study after study is that lower is better for the cholesterol. And so that's the one simple takeaway, that the lower your cholesterol, the lower the chance of a heart attack or stroke, seen in numerous studies. There's about 10 of them plotted here, but all of them fit this. So all of those were done with statins. Here's one with a non-statin. So ezetimibe, it used to be called Zetia. We said, well, statins are great, but should we just stop there, or should we keep pushing the cholesterol lower? And so in this study, we had 18,000 patients. For 6 years, we treated them and gave everyone a statin, and then half of them got also the ezetimibe. And you can see that pushed the LDL cholesterol lower. And just as had been seen with all the statin trials, the blue line with the two medications versus one has a lower risk of cardiac events out for a 6-year period. So further evidence that you lower the cholesterol, you lower the heart attack risk. Now, safety is also a big factor, and we know about, muscle aches is sometimes seen at about 5 to 8% of people with statins, and we can adjust. Here are the safety data for ezetimibe. There was no difference in anything in this 18,000 patient study. But that balance of making sure that something is safe is looked at in all of these different studies. So then the newest type of medication for cholesterol is a very strong one that, as you can see on the left, has a huge reduction in cholesterol by 60%. And this is on top of statins and ezetimibe in some of the people. So that the LDL level got down in the bottom corner, you can see, to 30 in this study. So the people who got statin and evolocumab is the name of this one, had LDL of 30. And then on the right, you can see the risk of heart attack, stroke, or death is significantly reduced when, again, you're lowering the cholesterol even further. So this theme keeps continuing. So they analyzed this the same way that very first study with all the different studies, but within this 27,000 patient study, and you can see lower is better. The lower the LDL cholesterol, and you can see it goes all the way down to close to zero, that the risk of a heart attack, stroke, or death is lower. So a remarkable finding to say that really every single study shows this same relationship. Now, this is a slide that I actually draw on the back of my patients' EKGs to illustrate how we use all this information for each individual patient. So this study actually looked with an ultrasound inside the arteries and measured exactly how much plaque is in there. And they can get the exact measurements. Then in a study, they'd have, say, regular dose statin or high dose statin, and they come back after a year and a half and they measure all the plaque again carefully, and they can see did more plaque develop, did new ones develop or not. And so then they plotted out the same story of the LDL cholesterol on the bottom, and here then the changes in the plaque. And so what's really interesting is that if we get the LDL to around 70, that's when all the plaques stay the same. The new ones don't develop, and whatever's there stays put and doesn't grow bigger. And then if you get the LDL below 70, the plaques actually start to shrink a little bit. And certainly they stabilize so that the risk of heart attack, stroke, as we've seen on all the prior slides, is lower. And so this then helps us see if we know that there's some plaque in the arteries, or if someone's had a heart attack, this is in part why we want to get the LDL below 70. So what do our guidelines say? Back now close to a decade ago, they highlighted 4 big groups of patients in the gray trapezoids there, the diamonds. People with known atherosclerotic cardiovascular disease, so prior heart attack, stent, et cetera, that's the most important. Some people have really high LDLs, usually genetically determined, of greater than 190. So those people are high risk. Patients with diabetes have lots of different things making trouble for the arteries. And so those are patients who benefit from statins. And then if not, there's an equation, the ASCVD risk score, that one can Google and calculate for yourself. And we do it on every patient in the office, that if that risk over a 10-year period of having a heart attack or stroke is greater than 7.5%, then that first study I showed you says, it's worth it to try and reduce that risk. It'll go down by about 40% to say, 4% if you take a statin, if it's at 7.5. So beyond the statins, then what we do is we adjust the medications to get the LDL to where we need it. And so, the less than 70 for anyone who has known heart disease, we would start on the statins, adjust the dose. If the LDL cholesterol was still above 70, then we'd add the next medication, ezetimibe. Then we'd recheck a month or so later. And if it's still above 70, then we'd think about the third medication. It's given as injections every 2 weeks or a new one every 6 months, but is more expensive. So we keep that as a third line treatment. And then I won't focus on it, but then we look at the triglycerides, and there is a therapy that can help on that as well. So pretty simple algorithm, but one that I think makes sense based on all of what we have. And this is from our European guidelines that lays out the notion that the higher risk you are, the more intensive we should get on lowering the cholesterol. So we were looking at the so-called high risk patients in red in the middle, where we want to get less than 70. For patients with risk factors, if you have high blood pressure and you've not had a heart attack, et cetera, then in orange, then we would try to get you less than 100. And that's good enough. Lower would be better, but, less than 100 is probably good enough. And then for people who've just had a heart attack or had 2 heart attacks, we've been pushing even lower still to go less than 55. On the very, very high risk patients. So it makes perfect sense that, you want to match the intensity of the treatment to how much problem there is. So you'd think with all of the wonderful studies that I've very briefly gone over that we'd all say, this is terrific. And so we did a registry over the last 3.5 years, and we looked at what are people getting. So these are all patients with known heart disease. And you can see most of them are getting a statin, but only half are getting the higher dose of the statin, which in theory is recommended on the guidelines that we just looked at. And then very few, 16 and up to 5% are getting the other agents as well. And over time, it's only increasing ever so slightly. It is improving, but more modestly than one would hope, because a lot of these people aren't getting all the benefits that they could. So how do we help that? Well, we have been delighted to be partnering with the Always Health partners on the Iheart Champion program. And so this is at least 3.5 years that we worked this out, where we said, we should try and help on blood pressure in addition to cholesterol. There are two parts of the program where it's a specialized, personalized program that we have a whole team of people that will work with patients to try and adjust the medications to get the blood pressure and the cholesterol down to the goal. And interestingly, it's all done remotely. So there are no office visits. We do it mostly by phone. And so it's really been an exciting collaboration. This is what's behind the scenes on this Iheart Champion, that it's a big program with lots of people. And so we start with patient navigators. And so we have one of them has joined us, Curtis, who's available for questions, who are all college graduate, but are not, medical or nurses or other licensed professionals. But they're available to, be able to contact back and forth each week if needed, address questions, do education, gather the information, work with people on getting labs. So have someone there to work with people in the program. Then we have pharmacists who are able within our program to prescribe and up-titrate the treatments if it follows the standard algorithm. And then behind that, there are docs like myself who are available if there are any questions that come up or issues, or if someone has side effects that need checking, that we're a part of the program. And then there's a whole software team that's equal in size to the clinical team that has developed the technology to pull in all the information, the lab work and stuff from the electronic chart. For the blood pressure program, we get blood pressure sent in from the blood pressure cuffs, and then has the standard algorithm that says, oh, if the cholesterol is still too high, the next thing we do is up-titrate the dose of the statin and recheck in a month. And so all of that is built into a software program that then our whole team will work with. So it's at the bottom says a remote care delivery platform. So a really neat thing to have as part of it. So in this program across the whole Mass General Brigham system, we've enrolled over 10,000 patients, and that our program has involved 100,000 phone calls and 400,000 blood pressures and I guess 27,000 prescriptions. That it's been an amazing program to be a part of. And so here are the actual data for enrollment in the Iheart Champion component of this program. So over 1,300 patients. And the LDL cholesterol, you can see, started out at 130. This is shown all the way on the right. And then in people who finished the program, we got it down to 72. And that's a mix of less than 70 for people with heart disease or less than 100 for those without heart disease. And then the blood pressure program had similar reductions in blood pressure. So wonderful, ability to get people to their goals and control these major risk factors. So out of this, for Heart Month here, I think the conclusions are that I've tried to share some of the data that, on diet, statins and non-statins, all of them have the same message that if we lower the bad cholesterol, it reduces the risk of death, heart attack, stroke, need for, stenting and bypass surgery. And the simple takeaway is that LDL is the key focus and lower is better. Then having support like the Iheart Champion program really helps people achieve their cholesterol and blood pressure goals. So with that, I'll stop and then am delighted to answer any questions that people have. And I could introduce Curtis is joining us as one of the patient navigators who works with many of the people in the program, and Iheart Champion is also available as well.
Great, thank you. Dr. Cannon or Curtis, can you tell us how somebody can join the program or if there are certain prerequisites to joining Iheart Champion?
Certainly. You know what? Let me pull up the final slide here that has some of the contact. So here, sorry.
Nope.
There we go. So the main Always Health Partners website is listed at the top, and then there is an email that nicely is Iheart Champion, and then the standard Brigham email is at bwh.harvard.edu. And so we have the team will answer that and can get back to you. The simple enrollment is being part of Always Health Partners. And then if your cholesterol is higher than it should be, and so in people with some level of cardiac risk. So the slide I showed of the 4 different groups would be the first thing that we'd assess. So is there any prior heart disease, diabetes, say, or if we run the risk score, is that above 7.5%, where we'd say, one should really treat the cholesterol level. But if you reach out, we can help sort that out as to whether it's needed or not.
Great, thank you. And then for folks on the phone, if you have questions for Dr. Cannon, can you please use the chat feature? And we'll get those questions over to Dr. Cannon. Give folks just a moment here. Oh, here we go. So question here, one question is there a charge for the Iheart Champion program?
Answer no. So this is one of the best things that, and we have been so thrilled, for all of the hair pulling out that has left me with much less hair that we go through with most insurance companies. And sorry if I'm doing but the insurance company said, this is good for our patients, we're going to offer it. So they pay. And so it's simply helping people get to the goal. And I think it's smart because if you control the cholesterol and blood pressure, then you're not landing in the hospital and needing a stent or whatever else. So it makes good sense, but it's a wonderful, program for the patient. So.
Wonderful, wonderful. And I do know this is a covered benefit, I believe, for the majority of our membership, but if you have any questions about coverage, call the customer service number on the back of your Always Health Partners ID card just to verify benefits, so you can talk with folks at Iheart Champion who can give you a hand with that as well. So thank you. Next question that came in was, is there a particular diet that I should follow in order to help lower my cholesterol, prevent heart disease?
So it's a terrific question. And in short, there are probably some that are better than others, certainly. So the American Heart Association recommends sort of the classic low fat, high vegetables and whole grains, et cetera. And so that's, sort of the diet we know we're all supposed to follow. Less red meat, more, plant-based has certainly been a wonderful way. And thankfully, there's so many good foods that are available. There is a large study that studied the Mediterranean diet, and they demonstrated in a 7,000 patient study that there's a lower risk of heart attack, stroke, and death in people who follow a Mediterranean diet versus a standard, eat right type diet.
Yep.
And interestingly, they had a component there of supplementing with nuts, of walnuts and related things that actually did even better still. So one sometimes sees stuff about, are nuts good? And the answer is yes.
Thank you.
And then someone's typed in the question, are eggs still considered bad? So answer yes, they do have some cholesterol in them. They do have protein though. So I'm not an expert on diet, I should say, and I'm a moderate, I would say. I like to work with patients to sort of see, can one reduce the amount of saturated fat? But, my wife has an egg every morning. It's terrific protein. 2 eggs every day, that's a little much, but one certainly, and then sometimes people will have, sometimes just the egg whites and things. So trying to be mindful of the saturated fat is sort of the key bad actor. Other things, like red meat has a lot of saturated fat in it. Amazingly enough, a lot of crackers and things will. Processed foods often have things. So what I often suggest is you have to live though too. So to sort of do a screen through and read, some of the ingredients on the boxes and see, what percentage saturated fat, et cetera, is in this. And like Cheez-Its are delicious. Our kids love them. And they have tons of saturated fat in them. Whereas like Triscuits and things, not so bad, so even within a category, there'll be differences on how much saturated fat and things. And then I think adapting slowly is then a way that you can follow that, if we all went vegetarian or something one day to the next, it will help, but it's not often sustainable. So sort of making shifts little by little. And I think there are within Always in the overall program, there are resources that can also help.
Yes, and speaking, I'm actually a registered dietitian by training before I became the manager of health and wellness here. So I would echo your sentiments. Say yes, there is great information out there. I think before we send out the presentation, we can add a few more links, particularly around the Mediterranean diet and LDL lowering foods, just so people have something to look at. Additionally, even if you're not taking part in the program, but you have nutrition questions, our members do have a benefit to be able to speak with a registered dietitian, particularly around medical questions. So again, always check in on your benefits and we'll send some resources for you. So
That's
thank
terrific.
you. And we've got some more questions coming in here. I don't know if we have this up there, but do you know the percentage of enrolled patients who got to their goal on, let's see here.
So yes, I high intensity statin.
Thank
So
you.
that's a very good question. I should know it. And let me see if I can pull up. Well, in general, most of the people could get to the goal with just statins. And I want to say it's something like, 15 or 20% needed ezetimibe. And then only about 3 or 5% needed PCSK9. So actually mimicking, I'd say, those numbers from the program, but getting people to goal. And so, nicely, because most of the medications are generic, it's low cost, and it's just really a matter of working together to figure out what's the right one. And this includes people who have had trouble with statins that, cause muscle aches or things. And so we have a whole section of the algorithm that walks through. We will try low dose and even ultra low dose statins. So like half a pill 3 times a week of, say, rosuvastatin or atorvastatin can be used, get a good amount of lowering of LDL, but very often can avoid any issues, of side effects. But then, I guess another big takeaway is that even if there's no statin, if you tried all 5, that there are 4 different classes of drugs in the non-statins that none of them cause muscle aches. They're all have nothing to do with muscles. And so then you can get the LDL down to whatever level we want with all these different new medications. So it's really nice that if problems with statins had been a barrier before, we now have lots of options to not have, to get around that. And I guess another question I'm seeing, are there differences between the statins? Generally, no. They all do the same thing. Each one has been shown to prevent heart attack, stroke, et cetera. The only real difference is in how strong and how much they lower the LDL. So rosuvastatin is the strongest of them and can get up to like 55, sometimes even towards 60% reduction just with the rosuvastatin. Atorvastatin's next, and then simvastatin and pravastatin and others are sort of more moderate lowering of LDL. And so we take advantage of that. We try sort of the standard, but then if the cholesterol is high, we use one of the stronger ones. But it also gives us options to try different ones, if people have had any issues. So here's a good question. I guess, Lisa Beth, we might have you in here as well.
Sure.
What about the importance of eating more cholesterol-friendly foods, and then also talk about children being tested, et cetera?
Sure. Yeah.
You know,
So I haven't frequently in my career worked with children specifically. So I say certainly speak with their pediatrician, but there are some cholesterol-friendly foods. In addition to sort of avoiding the bad stuff like too much saturated fat, trans fat, red meat, etc., including foods with what's called soluble fiber can help bring cholesterol down a bit. It's not necessarily not a substitute necessarily for a pill or a significant medication, but things like oats, barley, apples. I think I had a list. 1 second here, and I can include a link to some of this. Um, Oats and barley, whole grains. Eggplant and okra actually have a lot of soluble fiber. I know people have strong feelings on okra. To Dr. Cannon's point, nuts again are shown to be helpful possibly in lowering LDL. And then things like apples, grapes, strawberries, and citrus also may help lower your bad cholesterol, and fatty fish can help as well. And I think there's a nice article out there that I was pulling some of these from ahead of time, so we can put a link to that when we send out the additional resources.
And I do share that, beyond even the cholesterol numbers, eating a healthy diet is healthy. It's just, I guess it's a non sequitur. But within all the less healthy foods, if one has to go to fast food places, that all of that can soak into the arteries and contribute to those plaques. And, a lifelong strategy, you can't just throw pills at stuff, that it's really a lifestyle strategy. Being active is something that, the guidelines would recommend 30 minutes a day, 5 times a week as the, recommended level of activity, the minimum recommended level. And obviously more is better. And that can help, interestingly, I think, on food choices. If you're exercising more, that you tend to go for the healthier foods. So another question about, what about testing children? And people in general, that there is about 1% of the population that has the sky high cholesterol levels. And so that can be important. And indeed, we talk about testing families. If I have a patient, a parent, who comes to me with a cholesterol of 200, the LDL cholesterol of 200, I'll go through the whole family tree and then do recommend that all of their children get tested. Because there are genetic factors that can have really high LDL levels that you want to find out about early. And also, thank you for raising the issue of fish oil. Things have kind of changed a little on the fish oil recommendations. That 20 plus years ago, there were 2 studies with fish oil given one capsule, about a gram a day, that showed a lower rate of heart attack or stroke over time in primary prevention. This was before there was as much statin use and general prevention as currently. There have since been 6 huge trials. The last one was 25,000 patients that have actually not found a benefit of the fish oil. So we've been backing away from the fish oil as a recommendation. I showed you briefly, if people have high triglycerides, there's a purified prescription level kind that's the EPA only component of omega-3 that's been shown in a big trial to provide benefit. But that is more after you get the regular bad cholesterol fix that we would assess that. But the general fish oil or omega-3, it's not wrong necessarily, but doesn't provide the benefit that we thought it once did.
Right. I have a question that's not on here, but we're just talking about this internally. In the past, folks were told, well, if your HDL is high or at a good level, you don't have to worry so much about your LDL. Is that no longer considered accurate?
So it's true that we really have de-emphasized, I'd say, the HDL or the so-called good cholesterol. What's been seen and known for decades is that if you have a low good cholesterol, those people tend to have higher risk of heart attack, stroke, death, et cetera. What we've seen, we've done trials, medications have been developed that raise the HDL, but it didn't do anything in terms of preventing heart attack or stroke. And so what we've come to realize, and through genetic studies as well, is that the low HDL is actually more of a marker of other bad things. So it turns out that if you have a low HDL, those people tend to be overweight or obese, have diabetes, be less active physically, be cigarette smokers, amongst others. And so the higher risk of heart attack, stroke has to do with being less active, smoking cigarettes, having diabetes, and not necessarily the HDL itself. And so all of the studies have shown, for 50 years now, it's really the LDL that is the key. And then triglycerides are bad after that we do go checking. That's a second kind of bad cholesterol. And there's actually a third one as well, lipoprotein A, that we don't measure routinely. But the so-called good cholesterol tends to be more of a marker. So if you have a high HDL, it's not a get out of jail free card. And my mom actually had this, that we had to say, no, we have to focus also on the LDL, and make sure that meets the guideline recommendations. It's, around 100 for most people, and then lower for if you have heart disease.
Great. I had one more question that came in separately under the Q&A, which was, what inspired you to become a cardiologist?
Well, my dad. So my dad was a cardiologist, and he did more basic research, and he'd be writing papers at home back when you'd actually write papers on a yellow
Mm.
pad, and the so-called cut and paste that we do in word processors. So he would actually do that, with scissors. He'd do the first draft of the paper and said, "Oh no, I want to move this sentence here." So he's cutting out the thing and then pasting it back, and the secretary would retype it. And so I thought, science, medicine, that's pretty good. And then, as I did get into medical school and whatnot, that within medicine, so many advances are happening in cardiology, and it's just been an amazing time. I guess it's about 35 or so years for me that every a few months there's some new advance somewhere in cardiology. So it's been wonderful to have lots of things to offer to overcome all of this. Interestingly, my dad had started out studying the kidney, but then his dad had a heart attack. And so my grandfather, and he started researching and said, everyone talks about blood flow in the heart, arteries, but no one's actually measured it. And so he started developing ways to measure blood flow, and did lots of different studies. And so I guess it has run in the family, and that inspired being able to find ways to overcome heart disease. And it's just been a wonderful time, with advances in research and what medications and stuff, but equally so on the implementation, is the term, like a program like Iheart Champion that we talk about. Of we need to not just have the medications, we need programs, we need support people who can call you on the phone and help answer questions, adjust, et cetera. And so that's actually the main focus now. I still do some of these research studies that we've looked at, but being a part of the programs that try and get the good treatments to patients is really a key part of healthcare today. So it's been a fun, really wonderful time overall.
Wonderful. Well, this has been great. I know I've learned a lot, and clearly from all the questions we've had coming in, everyone's really gotten a lot out of this presentation. So thank you again. For folks who are on with us, again, we'll be sending out presentation, and we'll add some additional resources to the additional resources. We're also going to send a quick questionnaire. We hope you'll take a few minutes to answer that. So thank you again, Dr. Cannon. This was wonderful. And thank you everyone for participating. Have a good day.
Thanks so much. Bye-bye.